other sort of important palliative care stuff for people working in all settings. We had tried to direct these webinars to people working in primary care, so GPs, GP registrars, perhaps other sort of clinical staff in primary care. And we're talking a little bit about Cardiff and Wales services. I can see that lots of people have joined us from elsewhere in Wales, which is brilliant. So welcome to everybody. If we're talking about anything that's specifically Cardiff and Vale, which I think we will be a little bit later when we talk about oxygen services, you just need to make sure that you know how to do that in your own local area. So I will just introduce myself, if that's okay. My name's Dr. Jo Hayes. I'm a consultant in palliative medicine. I'm based at the Marie Curie Hospice in Penarth, which is near Cardiff, for anyone that doesn't know, but my main clinical role is community palliative care. So out there seeing people who wish to stay at home and want to be at home, and helping to manage those people in partnership with district nurses and their primary care team. I'll just introduce James, my colleague, or do you want to introduce yourself, James?
Hi, I'm James Davis. I'm one of the consultants in City Hospice. So we're again community palliative care covering Cardiff. So same as Joe, really working within primary care with lots of different people, lots of different teams to try and support people in their own homes. So I think hopefully we'll come from a background which is relevant to everybody working in in primary care. Initially, I'm going to turn my camera off because I'm in charge of slides and Joe's going to do the first bit, so I don't want to be distracting here. But yeah, so welcome everybody who's joined.
Thank you. Charlotte, if you're there and you're able to join us and people can hear you, could you just let everybody know what they want to do about the chat function, Q&A and that sort of stuff?
Absolutely, thanks Joe. So we've got the Q&A open, so if anybody's got any questions, pop them in there. Any troubleshooting problems you can't hear, something technical, pop it in there and I'm here to sort of respond to that.
And I think we've got maybe 10 to 15 people on this call. So if anybody's desperate, small manageable numbers. So if anybody is desperate to ask a question, by all means, put your hands up and we'll see how we get on with people asking questions as we go, if you wish. Okay, should we do the next slide, please, James? Thank you. So we're going to talk a bit about breathlessness and how we would manage breathlessness within a palliative care setting. And breathlessness in sort of different conditions. So there's lots of overlap in how we might treat breathlessness in heart failure and in COPD and in pulmonary fibrosis, but there's also specific differences, as I'm sure you know. So, we'd obviously be considering diuretics for cardiac failure. For COPD, we'd be optimizing COPD treatments. For pulmonary fibrosis, people might have a bigger oxygen requirement, and we might well be involved in the sort of specialist pulmonary fibrosis teams, but we'll be talking about the sort of overlaps between the two. So as the slide says, general impact of breathlessness on patients, how we assess, and drug and non-drug treatments for breathlessness. Thanks. Next slide, please. So have a little think about what breathlessness actually is. But I think those of us who work clinically are used to thinking about sort of abnormal or pathological breathlessness. But obviously, if I made you sort of run up and down the hill that's outside this hospice a few times, you would be breathless. Some of you earlier than others. For myself, I'd be breathless quite soon, I think, with my current level of fitness. But I hopefully wouldn't be hypoxic. And hopefully there isn't anything clinically actually wrong with me other than a sort of general fitness point of view. So breathlessness isn't necessarily pathological, it's a physiological response, but there's also obviously is pathological breathlessness that we're often trying to manage with our palliative care patients. And it's a little bit like pain, really, and it is what the patient says it is. So quite often and I'm sure you will be told by people that they are breathless. And when you see them, they may seem perfectly comfortable. And often people will tell me they're breathless, but not spend too much time drawing breath and are able to speak 10 to the dozen for as long as they want. But some of that is their subjective sensation, some of it might be anxiety related, some of it might be because I'm talking to them when they're sitting still in a chair and I haven't actually asked them to do anything. So obviously varies in intensity, and breathlessness can be really quite tricky to actually measure. There's lots of fancy measurements about how you might measure breathlessness, but none of them work particularly well, and therefore it's quite difficult to know if you've definitely improved things if you can't measure very well. And as I've mentioned, breathlessness has lots and lots of different causes, and we'll go over those a bit later on in the talk. But as well as the physical causes of breathlessness that you're probably now thinking about, there's lots of sort of higher centre stuff like anxiety and psychological distress feeding into that, and a sort of vicious cycle between breathlessness and panic. Okay, so as I've just said, typically patients will present with breathlessness on exertion first, because you're sort of stressing yourself psychologically by exerting yourself. There's more sort of work that your heart and lungs are doing, and then that may well worsen as things progress to become breathless at rest. And as I'm sure you know, restricting breathing can have an absolutely enormous effect on activities of daily living and the impact of people on their quality of life. So, as it says there, reduces independence, takes away confidence and stops people from functioning socially, makes them feel anxious, which makes the breathlessness worse. If you don't do very much in terms of physical fitness, you get very deconditioned, and that means you can't do very much. So that's the basis of pulmonary rehab, isn't it? If you actually get people to exercise with COPD in a sort of controlled manner, then there's good evidence that that can improve physical function and sensations of breathlessness. So thank you. Next slide, please. So I'm not going to dwell too much on the pathophysiology of breathlessness. Lots of you will have learnt this lots of times in the past and may not necessarily remember it all, because you perhaps don't have to remember all of it to be able to do your clinical job, but it's complicated and has lots of different feed-ins through CNS mechanisms. Okay, so there's lots of the perception of breathlessness is fed by higher centres, so emotion, anxiety, what the breathlessness means to you. If you're very anxious, that your breathlessness means that your lungs are getting worse and worse, and as things worsen you might not be able to take a breath and fear sort of things like suffocation, then there's a huge amount of higher centre input driving it. Okay. Ventilatory drive has lots of different inputs as well, and as I said, I'm not going to dwell on it, but lots of you will be aware of things like hypoxic drive. So if you get hypoxic, your physiology stimulates your receptors in your lungs, which drives your brain to make you breathe deeply and breathe faster. Patients with conditions like COPD, for example, who are always a bit hypoxic, your higher centres become a bit desensitized to the hypoxia. And also there's also sort of CO2 receptors involved in this and driving your respiratory rate as well. Okay, next slide, please. So lots and lots of different causes of breathlessness, causes within the lung. And on the picture there, you can see some of the different causes. It's quite important to try to identify the cause rather than just assuming breathlessness is because of COPD or because of heart failure or because of pulmonary fibrosis. As with pain, really helpful to try to identify a mechanism, because then there may well be a specific treatment that you can use that would be helpful for your patient. So lots of different causes from within the lungs, the fibrosis itself, the COPD itself, things like lung cancer, mesothelioma, lung metastases, lymph nodes in various different places causing compression of the main bronchi and vessels in your lungs, pleural effusion, sort of squashing your lungs from the outside. And then respiratory muscle weakness, lymphangitis is in there. Infection is obviously a big cause of breathlessness. And for all, you know, you need to try and identify all of those reasons. So they're the sort of disease-specific things or condition-specific stuff that could cause breathlessness. Then we think about treatment. So, you know, cancer treatments can make you prone to infection. Radiotherapy can cause fibrosis. Lots of the drugs that we use can cause breathlessness, like beta blockers, if you're prone to sort of obstructive airways disease or asthma. General debility, we've already talked about, so deconditioning and muscle weakness. And there's concurrent stuff. So people with lung cancer might also have cardiac failure. Lots of people have got lots of comorbidities. Arrhythmias, so undiagnosed atrial fibrillation, for example, can make people breathless, especially when they're exerting themselves. So there's some of the causes that we might perhaps need to try and identify. So next slide, please. So breathlessness is really, really common. So 90% of patients with a primary lung cancer or lung metastases will report breathlessness. Many people who don't have any identified pathology in their lungs but have diagnosis of advanced cancer will be breathless. Breathlessness is really common towards the end of life. And I think that is probably a combination of deconditioning, general muscle weakness, and maybe some metabolic dysfunction as well as actual pathology within your lungs. Most COPD patients, as you know, will report breathlessness, very common in heart disease. And then you may not think that breathlessness is common in renal disease, but it is, and often to do with sort of fluid overload and an element of cardiac failure as well. So thank you. Next slide, please. James, do you want to come in there?
Yeah, I was just going to quickly comment. I mean, I can't believe that only 90% of COPD patients are breathless. I mean, it just seems, what are the other 10% doing? But yeah, I mean, I think it just goes to show how, you know, often people think of, you know, especially in malignancy, actually, well, it's all about pain. But to me, I mean, this can be a really, really distressing, horrible symptom if it's sort of intractable. And, you know, sometimes I find the degree of lung damage often doesn't correlate with how breathless someone is. So there's a gentleman I see he's pretty much not got much lung left at all and was functioning very well up until recently. Someone else can have a single what looks like a small lung cancer and be very breathless. So again, back to what you were saying before, Joe, I think the patient report of what the impact is, I think is going to be the main driver to sort of how you manage it and how you measure almost success in treatment. But yeah, but it was just a comment really, because every time I see that I think only 90%. I mean, I know that's what the studies say, but it's just, yeah, anyway, I'll shut up.
I'm assuming some of that is undiagnosed COPD that's shown up on a scan and people haven't yet complained of breathlessness or something along those lines.
Or someone hasn't asked them.
Yeah. So I apologise now. I think I got a little bit confused myself, didn't I, in talking about the physiology and the work of breathing and stuff. So James, if you were listening, is there anything we need to correct now in what I was saying there?
No, I mean, I think if we go back to the pathophysiology, I think the main takeaway from it is that it's complex and it's exactly like, as you said, it's exactly like pain. You've got, you know, if someone said to me, "You're not breathless," I would immediately start thinking about my breathing and feel breathless. And that's with absolutely no change to my physiology at all. It's like itch. You know, someone says, you know, if someone says they're itching, I'm automatically starting to itch. So I'll start to scratch myself now. So I think the higher center stuff is important. And when we're talking about management, the bits about sort of the lungs themselves and what you can do in terms of reversibility is pretty much what you're doing on a respiratory level or potentially a metabolic level. The other sort of general things that we do are very much on the higher level and trying to rewire someone's thinking, or rewire the way they respond to breathlessness. So I think it's, predominantly, the other thing to say about, things like metabolic is CO2 is important. We'll come to talk about it when we talk about oxygen and COPD, is the importance of that in, not sort of giving too much oxygen to someone who's going to be overly sensitive to it. But we can come back to that.
Yeah.
I mean,
apologies. I was saying oxygen when I meant CO2 at times in that. So you all probably know that some of your COPD patients who've got chronically high CO2s become a bit desensitized to that, and then you can't sort of remove their hypoxic drive, if you like. Yeah. Okay. Thank you. So when it's really important to take a good history, like everything in medicine and clinical practice, if you're trying to define a cause of breathlessness. So, if they have gradually had increasing breathlessness over years, that would fit with a condition such as COPD, for example. If they weren't breathless this morning and they're suddenly really breathless now with a very acute onset, then that's potentially going to fit with a condition like a pulmonary embolus or something like that. If they've been breathless for a few days and coughing up gunk off their chest, then it fits with infection. So obviously lots of this stuff, but it's really important to try to define it. The associated symptoms are what we use to try to distinguish an infection from a PE, from a pleural effusion, or from something that's intrinsic to your lungs, like a cancer or a pulmonary fibrosis. And so that's why it's important to ask all of those questions. Hemoptysis is associated with cancer and with major infections, TB, for example, and then the wheeze and stridor could be associated with lymph nodes or something compressing one of the major airways. So pulse oximetry is useful and fairly important when you're managing breathlessness, but the numbers are not the most important thing, I would say, especially in the palliative care patients, and how the patient looks and feels is perhaps more important. But knowing what their oxygen saturations actually are can be useful and give you further helpful information. So what makes the breathlessness better or worse? Commonly moving around will stress your physiology and make your breathing worse. If people get suddenly very breathless sitting down, then that might well be associated with anxiety or things like pulmonary emboli, perhaps. I don't have the figures off the top of my head, but the figures for depression in chronic lung diseases like COPD are very high, and lots of people will have associated depression, which again can feed the anxiety and breathlessness. Okay. Environment and social situations have an impact, like with everything. From a medical history point of view, people have very rarely got one thing wrong with them, and there will be lots of comorbidities and things playing in their history. Did they have old-fashioned chemotherapy or radiotherapy several years ago, which is starting to affect their lungs? Are they on any of the medicines that we've talked about, such as beta blockers and non-steroidals? And what coping strategies do they have? So we'll probably talk a little bit later about some of the non-drug ways to try to manage breathlessness, in terms of being calm, relaxing, using a handheld fan, etc. Okay, next slide, please.
Just very quick, I think smoking is important, isn't it, as well? Because if we're thinking about if you are thinking about giving someone oxygen, then if they're smoking at home, essentially it's a no. So a smoking history is important. It's not to say, well, you ask someone with COPD, you're smoking, they think you're going to tell them off. By the time we see them, it may be, there still is a benefit to stopping, but lots of people probably aren't going to, or if they've got lung cancer. Not everyone, but some people. But it's important in terms of whether you can actually put oxygen in the house safely or not. So probably an important part of the social history.
And the oxygen suppliers and the chronic respiratory teams will want people to have stopped smoking for 3 months is the question that they ask. So I stopped yesterday. It doesn't necessarily allow you to have oxygen in your house, as you can understand, but it's quite tricky negotiation sometimes with palliative care patients. Okay. So investigate only if you think it's going to be useful. With some of the palliative care patients, they may not want things like hospital admission or lots of tests and scans. And so, like everything in palliative care, we sort of use your tests in a sort of an appropriate way. So we haven't talked about examining the patients first of all, have we, as part of your clinical assessment? Obviously, it's really difficult over the phone or virtually to do a proper assessment because listening to people's chests is important. So you're sort of feeding all your clinical information into your potential diagnosis. And then a chest x-ray could be useful. It's obviously going to give you information about, you know, whether people have got a pleural effusion, whether they've got obvious cardiac failure, whether they've got an obvious infection, or and can tell you whether the lung cancer's grown. But quite difficult to tell that from a plain x-ray. The good thing about x-rays is that they don't take very long to do and can normally be done reasonably close to home. So that might be something that would be useful. Bloods are relatively easy to do, even for people that can't leave their house. It can be done by community phlebotomy, and things like whether people are significantly anemic, whether they have got deteriorating renal function, and the infection markers can guide you to the causes of your breathlessness. And then the specific investigations there, then you'd want to only use those in specific circumstances. So, you know, CTPA, looking for pulmonary emboli. If you've got a reasonable history of a pulmonary embolus and it's appropriate to send that person to an acute hospital, then we might want to consider that sort of thing. ECGs and echoes for cardiac failure, obviously, yeah, a long wait in terms of many months as an outpatient for echo at the moment. And then the role of BNP and BNP levels in cardiac failure. Yeah, and peak flows and movement, you know, more than that, spirometry and proper respiratory function can be useful for people like pulmonary fibrosis patients. Okay, so yes, just a advanced care planning sort of comment at the bottom there. Consider what patients want and don't do unnecessary tests if it won't change management. So if patients are, you know, clearly dying and don't want to go to the acute sector, then you're not going to be doing fancy scans and tests. We're going to be trying to treat those people symptomatically. Thanks. Next slide. Team working is the key with all things in palliative care and all things generally and all things within the community, I think. So those of us like James and I who work in specialist palliative care are used to trying to manage our patients in conjunction with or in partnership with them and their families. GPs and district nurses would be lots of our main core group of people for patients who are at home, and obviously carers and care home staff for those who are in nursing homes. But for you obviously also need people with the specialist knowledge. So we work quite closely with cardiology, with our respiratory team colleagues, constantly working with oncology. And when you do want medicines in the community, sort of got lots of input from community pharmacy as well, and pharmacy advice from secondary care. Okay, so palliative care work within a multidisciplinary team as well, and the makeup of those teams is slightly different for us and for City Hospice and around Wales. But most community palliative care teams will have specialist nurses, input from doctors, and then allied healthcare professional input, which might be a little bit variable, might be a core part of the palliative care team, or you might be able to access people like physiotherapists, occupational therapists, social work and psychological support staff, for example. You might be able to access those from community teams or from secondary care, or they could be a core part of your palliative care team. Okay, next slide, please. So general approach to management is reverse anything that is reversible if it's appropriate, if it's realistic, and if it's in line with patients' wishes. So you can treat infections with antibiotics, obviously. We'll come back to hypoxia and use of oxygen in the forthcoming slides, I think. If somebody's very breathless and significantly anemic, you can consider whether a blood transfusion might be helpful. So superior vena caval obstruction is an oncological emergency that if you don't work in oncology and palliative care, you may not see often, but patients who have got lung cancers with mediastinal involvement or other conditions with lots of lymph node involvement in their chests could well be prone to superior vena caval obstruction. So those sort of patients will often look a bit cyanosed, be quite edematous in the sort of top half of their body where the SVC is draining, so may well have a puffy face or puffy arms. You can sometimes see prominent veins across their chest, and it, you know, later on, as well as being breathless, they can also be quite confused. So treatment of SVC obstruction, if patients are towards the end of life and acute admission isn't appropriate, then you would just treat symptomatically at home. For those people where it's appropriate to be a bit more active, then you would be admitting those people to hospital, where we would use treatments like steroids, possibly palliative radiotherapy, or maybe SVC stenting if you're in an appropriate centre. So pericardium pleural effusions can be drained if appropriate. Obviously, ascites could be drained, and you can sometimes intervene for sort of major airway obstructions as well, and sometimes put sort of main bronchi stents and things in to try and relieve breathlessness in that way. Next slide, please. So non-drug measurement, we've talked about lots of psychological and higher centre stuff playing into breathlessness, and drugs are often not particularly great for breathlessness and may not be the answer, and non-pharmacological management can be more effective. So simple handheld fan therapy can be really helpful. And I don't know if you think back to times in your life when you might have worked in hospital, there's lots of people with oxygen sort of lying on their beds or on their chest, or people holding it to the side of their face because the airflow across your face and the receptors in your nose and throat, if you stimulate them, can reduce the sensation of breathlessness. Okay, that's why I think COPD patients can often open a window or open a door or stand in the wind or whatever to try and relieve their breathlessness. We talked a little bit about pulmonary rehabilitation. You talk to COPD patients about doing some more exercise, they may laugh at you and say, I can't move off this chair, love. But if you can get them to pulmonary rehab and doing a little bit of controlled exercise in a sort of safe environment, that reduces the deconditioning and can be great for symptomatic breathlessness. So be inspired, and the sort of breathing techniques there are the kind of things that our allied health professional colleagues often teach people. So the physios and the occupational therapists about how to relax breathing, things like breathing around a square or visualizing or relaxing themselves. With the COPD patients, sort of teaching people to breathe in for a count of 1 and out for a count of 3 to try to reduce the hyperexpanded chest and things. Positioning is important, and you've probably all seen really breathless asthma and COPD patients who will put their arms up on a bedside locker to try to help their accessory muscles to breathe. And heart failure patients are often quite orthopneic and sleep on lots and lots of pillows, so a backrest or a hospital bed where you can press the button and sit yourself up can be quite useful. So mobility aids, sort of things like walking frames to help people who are breathless, or perhaps, you know, shower seats or perching stools so they can have a rest, and that sort of thing can be really helpful. And pacing, you know, acknowledging that you will become breathless if you try to do too much too quickly, and to try to move in a more controlled manner to allow yourself to sort of slowly, for example, get dressed if you're very breathless. Complementary therapies can be really helpful from a sort of relaxation and managing anxiety point of view. So reflexology, acupuncture, hypnotherapy. We certainly have hypnotherapy here at the hospice to try to sort of teach relaxation and techniques for managing breathlessness. And counselling, I guess, to address all of the fear and what does this mean to me elements of breathlessness and what it means for the underlying condition. The next slide, please. Okay, so quickly, so that we can get onto cases, pharmacological management. Opioids are the mainstay of treatment of breathlessness, and there's quite good evidence for morphine as a treatment for breathlessness. So people may, with lung cancer, COPD, etc., may well be taking morphine for breathlessness rather than pain, and it's worth bearing that in mind when you see patients. Starting doses can be quite small, and small doses can be very effective for breathlessness. Often things like 2.5 milligrams 3 or 4 times a day can be really helpful. People could take breathlessness in a preemptive take morphine in a preemptive or anticipatory way. People who are very breathless, who want to go to the bathroom and have time, could take the Oromorph and then try to move in sort of 10-15 minutes time, and that may well be effective. Okay, and then those people who are taking regular Oromorph and finding it helpful and they've got more of a background breathlessness may benefit from sustained release morphine. So we do use oxycodone if people don't tolerate morphine particularly well for whatever reason. We think it's a class effect of this particular class of opioids, but there's less trial evidence for oxycodone. And as with anybody using strong opioids, you need to make sure that they have anti-sickness medicines and laxatives available and monitor their bowels. Next slide, please. So benzodiazepines, no good evidence for benzodiazepines for breathlessness as such, but I'm sure you can see that if you're very, very anxious and that's driving your breathlessness in a sort of vicious cycle, I'm anxious, I'm frightened, therefore I feel more breathless, therefore that makes me feel more anxious and frightened, and you're getting yourself into a very vicious cycle, then treatment with benzodiazepines can be really useful. But I wouldn't use benzodiazepines for somebody who was breathless but not particularly anxious or not anxious at all, which and there are those people out there. If there's a strong anxiety element and it's more than just being anxious because of breathing, then people may well need proper anti-anxiety treatment with things like SSRIs. And with oxygen, I think James is about to speak a little bit about oxygen, but first of all, there's sort of poor clinical evidence of benefit for in breathlessness. If people are hypoxic, then it may well be worth considering oxygen. And there's not a great correlation between level of hypoxia and the sensation of breathlessness. And we've already talked about whether people are smoking and how that will prevent you from having oxygen at home for all those good safety reasons that we know about. We've all seen seen explosions happening in the community. Next slide, please. Okay, so yeah, oxygen generally only a use if hypoxic, might be worth a trial to see if there's any benefit, and this is the bit that often doesn't happen, to remove it if it's not actually working. Okay, might be better to have a formal oxygen assessment if you've got time and if that's appropriate and if patients can get to you. Yeah, we're used to aiming for SATs of 88 to 92, aren't we, for COPD patients? And James is going to talk a little bit about how we might request oxygen, I think, because it's something that we often get asked from palliative care. I don't think I can get oxygen from the community. Can you help me? Do you want to go through the oxygen?
Yeah, sure. I think first of all, I mean, oxygen can be put in quickly, within 4 hours, but sometimes, even quicker than that if it's needed. But I think, as Joe says, there's a difference between palliative oxygen and people. There's different oxygen for prognostic benefit in someone who has certain criteria and hypoxia and prognosis is longer versus someone actually who's approaching the end of life and we're doing it for symptoms. So as I say, if someone's hypoxic, you're more likely to get a benefit, but not always. Whereas if someone isn't hypoxic, you're less likely to get a benefit. But for some people, it may be helpful, especially if they said, I had oxygen in hospital and it really helped. But it's that review and taking it out, which is the important thing. So in terms of how I'm going to share my screen a second. There's a link on the Cardiff and Vale. Can you see my screen, Joe?
Yeah.
Yeah, so there's a link on the Cardiff and Vale sort of new SharePoint, the new intranet. And if you go to O, makes sense, and then you go down to oxygen services for home, then there is a lot of information on requesting oxygen, criteria for oxygen, who to refer for what. And then there's a section there on palliative oxygen and how you go about referring it. There are 2 forms that usually you would need to fill out that are on there, and then it tells you who to refer to. And then there's sort of the palliative home oxygen guidelines, etc., all on there. So if someone's asking for oxygen and you are the GP or the prescriber, it's probably worth going to that on the Cardiff and Vale intranet site. So just hopefully a practical tip, which is quite helpful.
And also the community respiratory teams are very good at picking up the phone and helping people who are struggling with the oxygen ordering process and advising them. For those of you who are working in Cardiff and Vale, for those of you who are elsewhere, then it's worth finding out how that happens in your health board, either by asking your local respiratory teams or maybe palliative care. Okay.
I'm just re-uploading my files. My computer's on a bit of a go slow today. Apologies. I think that was oh no, that was segueing I think into breathlessness at the end of life, wasn't it? I think.
Yeah.
I'm
sorry.
Yeah,
Go on, James.
I was going to say we get lots of questions and lots of, there's often lots of angst and anguish about oxygen, sort of prescription and who has it, who doesn't. I think the main thing is not setting an expectation that it's going to be sort of a panacea for breathlessness. That actually for some people it is a management tool, but for a lot of people all the other stuff is just as important, if not more important. And usually through explanation with patients and families, you can sort of get over to them why actually oxygen, you can understand if you're a layperson, you think, well, if you're breathless, give me more oxygen, but actually why for lots of people it doesn't help. And for a certain group of people with who are sensitive or have a chronically high CO2, then actually oxygen can be dangerous. There we go.
Thank you. So breathlessness is really common at the end of life, even if you have not got anything that we know of wrong with your lungs. Obviously, morphine or a strong opioid would be part of your normal 4 anticipatory medicines, so something for pain and breathlessness, which would be your strong opioid. Midazolam would be the anxiolytic element, so the equivalent of your lorazepams and diazepams for people who are dying, and we'd always have an antiemetic available for people as a subcut injectable medicine for people who are dying, and an anti-secretory medication, which is commonly hyoscine hydrobromide people would be used to, or we're increasingly using glycopyrronium. And Buscopan, when I worked in North Wales many years ago, we were using Buscopan for respiratory secretions at end of life. None of those things are amazingly good, and the evidence is a bit scant. None of them are particularly better than another in terms of death rattle or secretions. Hyoscine hydrobromide crosses the blood-brain barrier and can make people confused and sedated, and is also quite a good antiemetic. Glycopyrronium doesn't. So if you are just trying to dry secretions a bit and don't want to sedate or risk causing confusion, then you might well go for glycopyrronium. We've talked about hospital bed. People who are breathless are commonly breathing through their mouth. There's lots of mouth issues for palliative and end-of-life care patients anyway. Be prone to sort of dry mouth because of all the medicines that they're on, and things like oral thrush are common. So good mouth care is really, really important. And things like biotin oral balance gel for just moisturising the mouth. And you can use that with nasal mucosa as well. Okay. Thanks, James. Any questions? If not, I'll leave that there and we'll talk about some cases if that's okay.
I'm assuming the silence means no. Lovely. Right. So I'll go through, I'm going to just go through a couple of cases and talk about maybe some of the more specific management for common chronic respiratory illnesses. So this is a case you can obviously you can read it yourself, but a 78-year-old with ischemic heart disease and AF, increasing breathlessness. PND is paroxysmal nocturnal dyspnea, so waking up very breathless, feeling like you're drowning at night, which is very unpleasant. Orthopnea, so that's difficulty or breathlessness lying flat with significant edema. That's their current medication. So they're an aspirin, statin, low-dose diuretic, and a low-dose beta blocker. Clinically, they're in fast atrial fibrillation, SATs are 94. They've got bibasal crepitations and edema to their thighs. Can anybody stick their hand up to say what their thoughts, what their first approaches would be here? And there's lots of different approaches, so don't be afraid to say that to stick your head above the parapet. It's not going to be wrong.
If anybody wants to type the answer into the Q&A, or I can unmute you all.
Otherwise, you're going to have to keep listening to me. I'll give you a moment to see if anybody wants to type in their initial thoughts. Lovely. So heart failure, yeah, exactly. So we're looking at someone with heart failure, and in terms of it's a very broad question, but in terms of what we need to think about, just some sort of brief headlines of what our thoughts are here. Rate control, yeah. We're getting a couple admit or not, yeah. Medication compliance. Some good stuff, yeah. Diuretics, good. Love it. Yeah, so good. I mean, I think it's a very broad question, isn't it? Because actually, I think, is the atrial fibrillation new? They're not on an anticoagulant. So it's thinking about, in this case, the first thing I'd be thinking of is in terms of where are we with this patient's illness? Are we at somebody who either doesn't want anything doing and wants to, doesn't want to go in and have things treated, or it is an appropriate and very much end stages of the disease, or is there something actually we can do to improve their pump function, improve their symptoms as a result? So part of that is back to the advanced care planning and patient wishes. And then we think about the specific medical things that we can do to improve, if it's appropriate, to improve people's, sort of symptom control, but also their pump function in cardiac failure. Predominantly talking about sort of left heart failure, or sorry, people with systolic dysfunction here, but there's a wide range. So the commonest causes of heart failure: coronary artery disease, hypertension, sort of different types of cardiomyopathy and valvular heart disease. But if you look, if you look up a list, if you go on Wikipedia, there are hundreds of causes of heart failure. But ultimately, sorry, that doesn't come across very well. But ultimately, the symptoms you get are going to be related to whether you've got predominantly left or right-sided heart failure, or a combination of the two. So in left-sided heart failure, it's you're looking at sort of predominantly effects on the lungs, so your lungs become congested, so significant breathlessness, orthopnea, PND, and then if you're hypoxic, that can lead to confusion, agitation. Whereas right-sided heart failure, you get more sort of edema, ascites, sort of a fluid buildup. Often there's a combination of the two, especially in end-stage heart failure, so you're going to see a bit of both. So you're going to be looking out for both. So it's much more prevalent as we get older, unfortunately, like every disease. And as I'm getting older, I'm starting to think, hang on, I'm moving groups there. So the prevalence for me is going up. But yeah, so it is it's common, that heart failure is common. And I think it's worth remembering for, see, if you're diagnosed with heart failure without a specific treatment, then actually at some point that's probably going to progress. But with proper treatment, we may be able to delay that. So I think somebody mentioned compliance. So yeah, if they're having a Chinese takeaway every night, that's not going to be good for their heart failure. That might actually be the first thing to do. And actually their compliance with medications. So if you can treat something reversible, so back to the general principles of looking after someone with a life-limiting illness, what do they want us to do? And actually, if you can treat something underlying and it's appropriate and they want it, then actually that's probably going to help symptoms as much as anything else. So thinking about sort of managing ischemic heart disease, valve disease, if appropriate, blood pressure management. In heart failure, there is some evidence that if somebody's iron deficient, giving IV iron improves function and symptom control. And then reviewing medicines, making sure that they're not taking things or doing things that's going to exacerbate it. Again, this is all needs to be taken into account with actually where this patient is. If they're clearly at the end of life, you're not going to be referring them for a valve replacement. And if they're having a tipple in the night, you're probably not going to be telling them off. So there's sort of 4 pillars of heart failure management. A beta blocker, and well, obviously, unless it's a contraindication, a beta blocker, and then so generally sort of bisoprolol. This chap is on a low dose of bisoprolol and is actually tachycardic. Did I even put his blood pressure in? Actually, I'm sure I did. That would have been useful, because if his blood pressure is low and he's in fast AF, then you're thinking about potentially admitting. But if his blood pressure is okay, you could increase his beta blocker. So either an ACE inhibitor or an angiotensin receptor blocker, or there's something called Entresto, which is sort of valsartan, and this sacubitril, which is sort of the new kid on the block. But they're sort of all grouped under the same action. Then a mineralocorticoid receptor antagonist, so an aldosterone antagonist, really, so spironolactone or a pleuronone. And then these were initially for diabetes, dapagliflozin or empagliflozin, but have been shown to have shown to have symptomatic and prognosis benefit in heart failure. So if you see someone with heart failure and it's appropriate to adjust these, then I think it's probably worth doing to optimize their heart failure, because that might help as much as anything else. If they're fluid overloaded like this patient, actually you're going to need a diuretic as well. So here they were on a low dose of furosemide, so that could potentially be increased, or potentially switch over to something like bumetanide, because the oral bioavailability is better. If you're then struggling, you're thinking about adding in a loop diuretic, a thiazide diuretic, so something like metolazone, but the combination is quite powerful, and it can have significant effects on people's blood pressure and renal function. So you need to be careful and confident in what you're doing. And then on a Wednesday, actually, I work in the supportive care team, doing a clinic in Landoc, but they work sort of 5 days a week, and potentially there may have been some patients you've seen who's had subcutaneous furosemide, which can work well because it tends to be gentler on the kidneys and you can get a good diuresis. But I wouldn't be expecting you guys to initiate that. Right, so that's a whistle-stop tour of heart failure management. In all of these, it's gonna be caveated by actually making sure that it's appropriate and what the patient wants, what we're doing. So what I'm talking about is not every patient needs this, but these are the things that we can do for patients if it's appropriate. And the other thing I should say is actually all the general management of breathlessness applies here. So that's looking at not the underlying cause of the breathlessness, but the management of it. So here I'm talking about specific management strategies. So thinking about something else that's common, so pulmonary fibrosis, it's essentially scarring of your lungs. So where your blood is being pumped through okay, but the interface between your lungs and where the gas exchange happens in with your blood vessels, there's something impairing it, that it's not happening properly. And so usually is a progressive illness and can result in significant breathlessness. And ultimately, if your heart is having to almost squeeze this blood through because the blood vessels constrict if there's not enough oxygen there, then you end up with potentially with right heart failure. So so going back to what we were talking about before, this is an extra pretty horrible pulmonary fibrosis. You know, if this person isn't breathless, I would eat my hat. There's loads of causes of pulmonary fibrosis, but those are sort of the more common ones. We'll see idiopathic pulmonary fibrosis, where there's no known cause identified. You've got ones associated with connective tissue disease like rheumatoid lung. We see people with environmental exposures, especially things like asbestosis. It obviously depends where you live. If there's weird and wonderful things like popcorn lung for people who work in popcorn factories, causing sort of hypersensitivity pneumonitis, is something called pigeon fancier's lung, which is triggered by things that are in bird droppings. Medication. So Joe spoke sort of intimated earlier about potentially things like chemotherapies causing pulmonary fibrosis. So there are lots of drugs that can do it. So worth having a look. And then you've got things like sarcoid. Most are progressive, and most people, if they've got pulmonary fibrosis, you would be referring to a specialist team to look for the underlying cause and to think about specific treatments. So again, the general management of breathlessness all applies. I think if appropriate, if somebody's got fibrosis, if you think about what's actually happening with their lungs, they haven't got much reserve. So most of these people will progress to be on oxygen. So if you chuck an infection on top of that, they just can't, their lungs can't cope with it, and they can decompensate very quickly. So aggressive treatment of infections. For specific patients, they may end up being on a transplant list, although far more people die on a transplant list than actually get a transplant, but some people do. If they've got pigeon fancier's lungs and they're up their loft with loads of pigeons every day, probably sensible to get rid of that. There are certain anti-fibrotic therapies in IPF, so pirfenidone and nintedanib, that can slow down fibrosis in patients if they're eligible for it. But it almost sounds contradictory, but your lungs have got to be good enough to have it. If your lungs are, if your lung function is very poor, you're not going to benefit from it. And they tend to have, I don't know what you think, fine, Joe, but you tend to have a lot of side effects with them. It can cause a lot of nausea. People often don't tolerate it. But for some people, it can slow the disease down, or slow the illness and progression down.
Yeah, I think we often see people that can't tolerate them, don't we? And then that sometimes is a trigger for referral to palliative care, which is fine. But and this is what you're doing, aren't you, James, with the supportive care team? It would be better to perhaps have some involvement with those people at an earlier stage.
Yeah, and we're doing all the other stuff around that. We've spoken about the general sort of management of breathlessness, and seeing that person as not just a set of lungs or a breathless person, but as a whole. Immunosuppression, so steroids, azathioprine, methotrexate, depending on the underlying cause. So that won't be for everybody. So IPF don't respond to steroids, so they wouldn't be on it. But in certain people, but again, that would be under the guidance of the of the respiratory specialists. And then management of right heart failure, where you can get sort of gross edema, and essentially it's diuretics, and it's that in itself is not a good sign. Something called cor pulmonale. I'm conscious of time, so I'm going to skip the discussion. Apologies for that, but I want to sort of try and finish on time, so I'm going to skip through this. Essentially, it's a patient with COPD who's on inhalers, and is SATs are sort of 88%, is a bit anxious, and is on a dose of mirtazapine. So thinking about COPD, the underlying pathology of it, you've got inflammation of your smaller airways, and then a loss of architecture of your alveoli, which are where all the gas exchange takes place. And there's a different, depending on the individual patient, you can have a predisposition to it causing the inflammation and sort of bronchitis type picture versus somebody who has lost a lot of their gas transfer surface with emphysema, although there's a huge overlap. Smoking is by far the most common cause, although you can get people with genetic mutations that mean that they don't have certain enzymes which can lead to this illness. And sort of pollution, it's shocking actually how many people die from air pollution a year, that we don't quite appreciate how important that is. Not a very flattering picture. And I'm not sure I hope I haven't got either of these physiques, but classically you talked about a blue bloater, which is someone with bronchitis, or a pink puffer, someone with emphysema. So if somebody who's a blue bloater tends to be have more right heart failure with sort of fluid retention and CO2 retention, and a chronic productive cough because you've got chronic inflammation there, versus someone who's a pink puffer with emphysema, who is working very hard to breathe, so loses weight, has that cachexia, but doesn't tend to have the edema, and they don't tend to retain CO2. This is a very arbitrary, old-fashioned way of thinking about it, because actually there's a significant overlap between them. So specific management, again, general management rules apply. Oxygen, again, if appropriate, and just caution with not, if somebody's got SATs at 88%, then thanks, Joe. Thanks, you gotta head off. Lovely. Great. I should be finishing soon, everybody. So oxygen if appropriate, but if somebody's potentially at risk of CO2 retention or known to have CO2 retention, aim for that 88 to 92. If they do have signs of CO2 retention, classically sort of being more sleepy, morning headache, sometimes confusion, and it's appropriate, they may benefit from an assessment by the respiratory team to look to see whether NIV might be helpful. Again, if they've got an infection, then treat it if that's appropriate and what they want. And then it's about optimization of the things that can help from a symptomatic point of view. So inhalers and possibly a nebulizer. If they're having recurrent infections, things like prophylactic antibiotics. So there are those patients that respond well to steroids, and sometimes it's almost a psychological reliance on steroids. But for some patients, actually, it's the best of a bad situation going on a low dose of steroids. But think about the long-term effects of that. In a very small proportion of patients, you may be thinking quite aggressively of things like transplant or bolectomy, where you've got sort of big areas where no gas transfer occurs, but they need to have no other comorbidities really and be otherwise fit, which is a bit of an oxymoron when you've got severe COPD that severe. And again, people can go on to develop right heart failure and cor pulmonale. So again, manage that with sort of diuretics. But in itself, you see someone who's very fluid overloaded with COPD, and we're thinking right heart failure, that's probably a trigger to say, well, this isn't a good sign. We need to start thinking about the future with this person if we haven't already. Lovely. Apologies, that was a bit of a whistle-stop tour because I was conscious that this is only on till 3, so I didn't want to keep you too long. But has anybody got any questions, any comments, anything that they found difficult, tricky with breathlessness? We got a little bit of time now, to discuss. I think we'll probably stop the recording now. Is that okay, Charlotte? Just to give people a bit of anonymity in terms of the recording.